Hello, my name is Fari Ngongoni. I am a research resident working in the Division of Surgical Oncology in the Department of General Surgery at Stanford. My poster is on comparison of outcomes between laparoscopic transgastric necrosectomy and endoscopic cystgastrostomy. Laparoscopic transgastric necrosectomy and endoscopic cystgastrostomy are alternative approaches for debridement of retrogastric walled-off pancreatic necrosis when necrosum abuts the gastric wall. Comparative data for these minimally invasive approaches is sparse, and the study aims to be the first to compare outcomes between the two approaches. This is a retrospective study which included patients who had undergone laparoscopic transgastric necrosectomy or endoscopic cystgastrostomy as the initial definitive treatment for walled-off pancreatic necrosis between 2011 and 2021. Figure 1A and B show the endoscopic approach at our institution, with a view from the stomach of an axial stent opposing the lumen between the stomach and necrosum. Figure 1C shows the laparoscopic transgastric approach, where versostep ports are placed via the anterior abdominal wall into the stomach, where a surgical cystgastrostomy is made to allow for debridement of the necrosum, as shown in Figure 1D. After completion of data collection, bivariate analysis was performed using the student's t-test and Mann-Whitney U-test. Primary outcomes of interest were mortality, number of debridement procedures, and time to symptom resolution. 98 patients were included in the study. 43 had undergone endoscopic cystgastrostomy, and 55 had undergone the laparoscopic transgastric approach. 14% of patients in the endoscopic group had undergone a laparotomy, which precluded the laparoscopic approach. There were no differences in baseline characteristics, such as age, gender, BMI, and comorbidities between the two groups, except for splanchnic thrombosis, which was higher in the endoscopic group, as shown in Table 1. When we looked at the perioperative or periprocedural factors, we noted that a concurrent cholecystectomy was performed in 45% of patients in the laparoscopic group and in none of the patients in the endoscopic group. The surgical group had an average procedure duration of 151 minutes, which was more than twice as long as that of the endoscopic group at 69 minutes. Patients in the endoscopic group had an average of 3.7 debridements compared to 1.1 in the laparoscopic transgastric group. Although 16% of patients in the endoscopic group required additional surgical debridement, 8.8% of patients in the surgical group required additional endoscopic debridement. Laparoscopic transgastric necrosectomy provided single-step debridement for 89% of patients in the laparoscopic transgastric group, and this includes reoperation, endoscopic debridement, or placement of percutaneous drains by interventional radiology. Notably, patients in the laparoscopic transgastric group had shorter time to symptom resolution of 2.2 months compared to 7.1 months in the endoscopic group. There were no differences in Clavien-Dinder grade 3 or higher complications or mortality. In conclusion, laparoscopic transgastric necrosectomy and endoscopic cystgastrostomy are complementary approaches with similar safety profiles. Laparoscopic transgastric necrosectomy offers single-stage debridement, may be combined with cholecystectomy, and appears to result in faster symptom resolution. Endoscopic cystgastrostomy is a multi-stage debridement with low upfront morbidity and is particularly suitable for patients in whom surgery is contraindicated. In the future, we would like to compare outcomes of laparoscopic and endoscopic approaches while considering advancement of endoscopic capabilities, such as use of wider lumen opposing metal stents and the endorotor. Thank you.